So why don't we just start out, Dr. Tepper, with the first question we have, which is how long does it take to bring a new medication or treatment to market in total?
It takes years and years, and it really depends on where you start, where you set the start point. But to give you a feel for how long it can take, the idea that CGRP might be a target in migraine was first raised in the late 1980s by Peter Goadsby and Lars Edmondson, who later shared the International Brain Prize for this hypothesis and what led to all of our most recent new medications, or most of them. And so that means it took 30 years to get from the idea that CGRP could be a target to the FDA approving the first anti-CGRP medication. And a lot of this has to do with companies deciding that something is worthwhile and devoting enough resources to it, and then the many steps to get to submission to the FDA. So you are talking 5, 10, 15 years from when a company decides to pursue something, often until FDA approval. But
Wow.
30 years is what I keep in my mind. With triptans, the first first findings by Pat Humphrey that led to the development of sumatriptan, from that point, it was at least 15 years before sumatriptan made it to the market, and even then only in limited forms. So 15 to 30 years.
That's really a long time. Just to dig down into one of those phases, if you wouldn't mind. I know I didn't give you this question ahead of time, so I apologize. But if you were just looking, that's the time taken in a phase 3, if all goes well, what are we looking at that? Because for a lot of patients, that's when we start paying attention to what is going on.
Phase 3 means that doses have been decided upon in earlier studies, and the FDA then mandates that companies do generally 2 large studies with the drug in question in one arm and placebo in the other arm. And there's a period of comparison to placebo, depending on whether it's an acute or preventive drug, that can be 6 months of studying the acute treatment, 3 to 6 months of studying the preventive treatment against placebo, with a placebo, after a 1 to 2 to 3 month run-in baseline period. And then the FDA requires a certain number of people take the medicine in what's referred to as an open label safety and tolerability trial, where the people get to take the drug the way it's supposed to be used once it's approved. And that's generally at least another 6 months, and it can be another year. So a regulatory trial doesn't always have to be called phase 3, but a pivotal trial is generally a year to a year and a half in duration, but it takes a long time to get 1,000 people into one of those studies. So it might take 2 or 3 years to complete a regulatory trial.
Right. Wow. So that's a lot of time. And then you've got to have 2 large trials. And then an NDA has to be submitted to the FDA, right? And then you have to wait for the PDUFA date. And then you have to wait for the medication actually to be ready to go to market.
All true. And the FDA, in the PDUFA Act, the FDA is supposed to make a ruling within 10 months. They never do that. They always take at least 12 months. And I think the companies feel powerless to try to hold the FDA to what the act actually says.
Right.
And so the FDA generally takes a year before even making a ruling, and they can say no. And if they say no, that's called a complete response letter, and that can then delay things a long time after that. So if the sponsor is lucky and they get their regulatory trials done in a couple of years and then submit, and the FDA agrees to take the submission, They can say no to that as well. Then it's another year before they hear from the FDA. And then, as you just said, it may take a while to actually get the factories up and running in order to get the medication out to people who need it.
Right. Wow. So if you had to give like a range of from the time it officially goes into phase 3, which means starting recruiting for those trials, to the time it may actually hit patients' hands in the market, what's the longest time? Could be as long as or it could be any number, right? What would be the shortest time?
Oh, I would think, I guess, conceivably a little over 2 years,
Okay,
conceivably, but
not too
that's
bad.
pretty short. That
That
would
would
be
be really
very,
short, right?
that
And
would
then
be very
everything would have to go
unusual.
right.
Yeah, everything would have to go right. It would be shorter for an acute medication. That is a medicine that's being taken for the migraine as needed, because then a single attack against placebo is what the FDA wants to see. They have a certain number of patients of people who would treat that single attack and then do the open label. So it could go faster for an acute medicine. For a preventive medicine, it's going to take even longer.
Wow, interesting. So let's just backtrack one phase, and we won't look at the other phases, but what generally is going on in phase 2?
In phase two, let's backtrack to phase one. The first
Absolutely.
thing you want to know is does this medicine have really concerning side effects?
Right.
And in phase one, what happens is what are referred to as healthy volunteers, that is for a migraine medicine, not somebody with migraine. Um, Healthy volunteers agree to take the new potential drug in different doses and look for side effects. And if the medication appears to be safe in that first phase where it's given to volunteers and the side effects are monitored, then they can go to phase two. And in phase two, what's done is to take several dosages of the drug and compare those to placebo. It's usually a smaller study, and it's referred to as a dose ranging study. The idea is to find the correct dose that has the least side effects that should be taken on for a pivotal trial to get FDA approval. Now, not all medications have to go through the 3 stages, and sometimes the FDA
Oh,
will say that a phase 2 dose ranging study is big enough to serve as a pivotal trial. So that can cut the time down a little bit. But
right.
most of the time, phase 1, healthy volunteers look for side effects and safety. Phase 2, try to establish the dose, and then and then 2 big regulatory trials against placebo with a safety extension trial. That's the sequence.
Well, and then before that, if we were going to back up even more, we're talking about preclinical and just research not even being done with healthy or unhealthy participants, right?
Right. So once a potential medication or target is selected, those medications have to be tested in animals for toxicity.
Right. Interesting. So it's a long process. So in case anybody is wondering why it takes so long, there you have it. It's a long time. If you learn about a treatment that's in phase 1, you've got a lot of years to wait. But even right now, we're going to learn about some of the treatments that are in phase 2. One in particular is very exciting. It's still several years away from coming to market, even in the best case scenario. But not all doom and gloom, because there's a lot of things in the clinical pipeline. So let's talk about the main challenges. We're going to get onto the details, everybody, of what the things are that are being researched right now and what are in clinical trials, including we're going to be looking at medical devices as well. But I just want to lay the foundation. So what are the main challenges that are faced during clinical trials?
I think the biggest challenge is you have to have people who are heroes to be in these trials because they could get placebo. And and also you never know where a side effect might come unexpectedly, and I've seen that as well. And for somebody to agree to be in a study, it's an act of it's heroism. They're being heroic. They're saying, look, I need to do this because I want to help other people. And it's risky. It's potentially risky. So they have to be willing to take a certain amount of risk. And So those two, and then finally, because of all of the new treatments that have been developed and are available, a lot of people are giving up what works in order to try something just because they think it's um, an important thing to do to help others. And so from my standpoint as an investigator, I sometimes do not recommend people going into trials because they had so many years of misery and they're finally in good shape. And I
Right.
think we shouldn't upset the apple cart. And also, I recognize that people have now in 2024 compared to a decade ago tremendous numbers of options,
Right.
and going into a trial means not doing those options for the period of the length of the trial. So
Right.
both my own concern about it and a potential participant concern about it represents an obstacle to quickly getting a trial done. But
Right.
my biggest obligation as an investigator is safety. And I think the investigators that care about what they're doing, they'll all say that. They'll say our number one priority is protecting participants in studies.
Right.
So that requires a lot of balance and deliberation and consideration.
Right, absolutely. That makes total sense. Thank you for sharing that. And so, right before we get into what all the details are, why don't we just talk about for a minute why so many of the medications specifically being studied are still focused on oral medications versus nasal sprays, injections, and other means specifically for acute medication.
Patients want pills. It's really patient driven.
Right.
People want pills. There's a certain group of people that won't take a nasal spray no matter how nicely it smells. Even if it smells like lilacs, they're not going to agree to do a nasal spray. They won't do a nasal spray even if it would help the space program. And then other people, same thing with injections. They'll say, look, I don't want to take an injection. I don't care that it's convenient. I just do not want a shot. And the majority of people in the US say they want oral.
Interesting.
The companies then try to accommodate that when they can, depending on the medication.
Right. Of course, we know that's frustrating because in migraine attacks, we have nausea and gastroparesis and throwing up. We have people, I think almost every day in my online community saying, hey, I took this oral tablet and I just threw up. What do I do? We're like,
Yep.
probably should have talked to your doctor ahead of time and tell them that you throw up. But it's frustrating. I know for myself, it was very difficult to accept having to use injections.
Yep. It's a big problem
Yeah.
trying to even convince people to do non-oral when you know they're going to need it.
Yeah.
When they vomit up the pills, when they have a full-blown migraine where a pill might be too slow because of the gastroparesis. So it's balancing what people want versus what they need.
Right. And that's often not the same thing at all.
No,
Right.
exactly. Yep.
It's not, it's really not. I know since I got off predominantly oral medications, it transformed my life in that I was no longer a frequent flyer to the emergency room.
Yep.
And all I could say is, did I want to take an injection? No. Did I want to use a nasal spray? Really, no, either. But the idea of going to the emergency room and all that involved, it was an obvious choice, but still not easy. And I know a lot of other people really struggle with that as well. So we're going to look at the things that are most promising that are currently in clinical trials. And maybe as we go through them, you could explain how they're different from what we already have. And if you want to touch on potential side effects, totally up to you. So let's start with the medication that should be coming to market first, I believe, which is AXS-07, which is just finished up phase 3 or somewhere around there.
No, yeah, AXS-07 is actually before the FDA, and the PDUFA date, meaning the date that the FDA is supposed to make a decision about it, is January 31st coming up.
Wow.
So we should know about AXS-07 at that time. And what AXS-07 is, it's a combination tablet that contains rizatriptan which is probably the fastest acting triptan
Right.
and probably the highest likelihood of 2-hour pain freedom. And it used to have the brand name Maxalt, combined with an anti-inflammatory called meloxicam. But it's a new formulation of meloxicam, which is a quick release form of meloxicam. Meloxicam has had the brand name Mobic, and it's a little different than the usual anti-inflammatories in that it uh, has less gastrointestinal side effects, and it has a very long duration of action. And so the idea would be if you combine the very quick onset rizatriptan with this new quick onset meloxicam, they would work together because triptans and nonsteroidal anti-inflammatories work by different mechanisms. And then the meloxicam would have a long duration of effect. And there is a precedent for this, and that was the combination sumatriptan naproxen sodium pill, which is Trexamet.
Right.
And again, in that particular pill, the naproxen sodium seems to kick in earlier. And in the brand name, the sumatriptan had a rapid release formulation. And when a company wants to uh, bring a combination migraine acute medicine to market, the FDA says they need to check whether the combination is better than the individual parts.
Right.
And so the AXS-07, we don't have a name for it yet. They compared the combination of the what's called mosaic meloxicam with rizatriptan to just the mosaic meloxicam alone, to just the rizatriptan alone, to placebo in 2 large pivotal trials, and then a safety and extension trial. And all of it was positive. So we hope the FDA will approve this in January, and it would be great to have a combination medicine with a company that supports it, and we can re-educate our providers and practitioners about the advantage of combining these kinds of medicines.
Yeah, absolutely. That makes a lot of sense. I know 2 of my sons used Trexamet when they were in their late teens, and it definitely helped them more than the individual medications did. So definitely looking forward to seeing this come out. Do you
Yep.
know, is that going to be in an oral tablet form, or is it
Yes,
in
it's an oral
this?
tablet. Yep.
Okay. Wonderful. Thank you. So now the next really exciting one, I would say this is particularly exciting because it's a whole new class of medications, and that's PACAP. Not sure how you pronounce that, but maybe you could talk a little bit about that because that's in phase 2B right now.
Right. And it is pronounced differently by different experts. So I'll call it PACAP, but
It
because
works.
the company said PACAP. PACAP, and forgive me for just saying it once, PACAP stands for pituitary adenylate cyclase activating polypeptide. And it's essentially a chemical, a peptide, which is released outside the brain, similarly to CGRP, and does many of the same things that CGRP does. It causes blood vessels to dilate, it causes inflammation, it causes pain. And in Denmark, there are 2 different kinds of PACAP. There's PACAP 27 and PACAP 38. And both of them in Denmark, they have very heroic patients there. They agreed to have the PACAP infused IV into the blood. These were people with migraine, and most of the people who got the PACAP 38 infused got a migraine-like headache within 2 to 4 hours, and many who got the PACAP 27 also got a migraine. It appears that PACAP can trigger a migraine, and the idea was developed that if one could create a monoclonal antibody against PACAP, that perhaps that could prevent migraine. Similarly to what we have with CGRP, we have 3 monoclonal antibodies that target CGRP and prevent migraine. So the race was on to see if this monoclonal antibody could be created. And one company did a study, a phase 2 study. So it was after having done the toxicity and the healthy volunteers, two different doses were tested against placebo. And this study was published in the New England Journal of Medicine in the last 6 weeks, I think. So very, very exciting.
Right.
And this medication was tested in those with migraine who had had at least 2 to 4 previous preventive medicines fail. So at least people had tried some stuff in order to be in the study. And it worked. That was the good news. And the side effects appeared to be minimal. And as a result, and this was in people who had either episodic or chronic migraine uh, from 18 years of age to 65 years of age. And they received, after a screening period, a single intravenous infusion over about 30 minutes. And then they evaluated the frequency of the migraine days in the first month after the intravenous treatment. So pretty quick to
Right.
evaluate it, but it did work. And then they followed the patients for a total of 3 months for safety. As a
Right.
result of that very positive study that has now been published, a second study, as you alluded to, a phase 2B trial is underway internationally. And initially, they're going to try this same medicine by a by a set of sub-Q injections, so that if it works sub-Q, people could administer it at home, which is much more convenient than coming in for an intravenous treatment. Although some people like quarterly intravenous treatments, but they'll evaluate how well the sub-Q injection works. If it works well, they'll continue that into a set of pivotal trials and safety and tolerability trials. If the sub-Q injection doesn't work, they'll switch back to the IV because that worked so well. And the great advantage here is that PACAP is not CGRP. So the hope is that it would work perhaps in people that did not get a response to anti-CGRP therapies. It might be additive to people who are on CGRP treatment but feel like they need a little booster, or it might be superior to
Right.
the anti-CGRP drugs and have even fewer side effects and be a first-line drug. We just don't know till we have larger trials on it. But if you ask me, which of all the medicines we discuss I'm most excited about, it's the anti-PACAP monoclonal antibody, because as you said, and it's very important to emphasize, this is a completely new class of medication, and we need all we can get for migraine people.
Definitely do. And I know for myself, I'm really, really excited about that. Whether or not it comes to market and whether or not, if it does, it helps me, I don't know, but it's good to have something to hope for and to look forward to as well. So the next on my list is, I'm going to let you say the whole name. So I'm just going to shorten it to the TRPM3 antagonists.
Okay. We have just a little bit of information about this group of medicines. Some of the medicines that are being tested have been shown to reverse certain receptors in the brain or outside the brain that appear to be associated with generating pain and inflammation. We have 2 on the list that I gave you. And this particular medication called BHV 2100 is an antagonist. That is, it blocks a particular receptor called transient receptor potential channel M. And this particular, the activation of TRPM3 is associated with inflammation and pain and heat. And there are TRPM3 receptors outside the brain, in the meninges and in the area of the trigeminal ganglion, which is where pain signals come into the brain. And it appeared in laboratory preclinical models that if you could stop the activation of the TRPM3 receptor, you might improve pain. You might normalize the pain function. And a phase 1 healthy volunteer study established that this medication worked rapidly by oral form. And they tried a bunch of different dosages and people didn't have significant side effects. So they have moved on to a phase 2 trial for the acute treatment of migraine. And that trial is underway right now. So there will be several dosages of this BHV 2100 that'll be tested versus placebo in the acute treatment of migraine.
Wow.
And beyond that, we don't know much. I mean, we know that it was well tolerated in the healthy volunteers. We know that the preclinical model suggests that this is a receptor that might be important in migraine pain. And now we get to find out whether it works and what dose might be effective in people for acute treatment. Obviously, this is a medicine that would not cause blood vessels to constrict, which is great. So that we hope that the side effects are minimal and that the effectiveness is high.
Wow, that's amazing. It's a whole new class of acute
Correct.
medication.
Another new class.
I love that. That also sounds like that may also be helpful in some other pain conditions. Is that being studied in other conditions?
I don't know, but yes, I think it should be studied in other pain conditions. I
Right.
completely agree. As is the next one, and I'm going to actually jump to the next one, which because it's so similar, and this is called the PAR2
Right.
receptor, and the PAR2 receptor is also called a protease activated receptor, has a bunch of other names. And PAR2 is associated with inflammation and also associated with blood vessels dilating and also associated, interestingly, with obesity. And once it's activated, there are some other receptors that get activated that have to do with opioid tolerance and with our ability to regulate pain through our opioid receptors. PAR2, then, as with the TRPM3, looks like it is a receptor that if we could reverse its activation or prevent its activation, we might be able to prevent migraine and again look at other pain conditions. And there have been a number of about a number of monoclonal antibodies that have been developed against PAR2. I was able to count 5 or 6, and they have been studied in human cells and in mouse cells. And so some companies are planning to do clinical trials on anti-PAR2 monoclonal antibodies for the prevention of migraine, for the prevention of other pain conditions. But to my knowledge, the last time I checked on clinicaltrials.gov, not one of these anti-PAR2 monoclonal antibody studies is yet running. I'm assuming it's going to happen over the next 6 months to a year, that we'll have one set of trials for an to antagonize a receptor preventively with a monoclonal antibody, and then we'll have this BHV 2100 study to see if a small molecule antagonizing a receptor that is associated with activation of pain might work acutely for migraine. And both are exciting because both represent new classes of potential medications, new potential targets. Takes a while to work through safety, tolerability, dosing, but certainly worth keeping an eye on.
Yes, definitely. And obviously, we all know that there's so many comorbidities that go alongside migraine and comorbid pain conditions specifically. And so I know obviously it would be wonderful to be able to use one medication and deal with more than one type of pain. Maybe that's just my own personal dream, but it would definitely, seems to me that would be amazing if that happened.
I agree. It would be fantastic.
Yeah. All right, let's move on to, I'm going to skip the ones that are just get a variant of what we've already had, and we'll come back to that at the end. And let's look at the serotonin XC101 D13H.
This one, I don't know where it stands clinically, but if you are aware of serotonin, Serotonin is a key chemical having to do with the activation of migraine. And if you activate certain serotonin receptors, you can terminate migraine. And that is what triptans do. They activate the serotonin 1B, 1D receptors. That's what ergots do partially. They also activate serotonin 1B and 1D receptors. And the new medicine, or not that new, but over the last couple of years, lasmiditan or Rayvow activates a serotonin 1F receptor and can stop migraine. We know that activation of serotonin, certain serotonin receptors can stop migraine and can prevent migraine. But there's always a but. The problem is that some of the serotonin receptors have pretty bad side effects. And the serotonin 2A receptor, if you activate that receptor, then people can have all sorts of bad psychotic side effects. They can have delirium. They can have what's called serotonin syndrome, which is life-threatening. So activating the serotonin 2A receptor, bad. Activating the serotonin 2B receptor over a long period of time is associated with scar tissue formation in between 1 in 1,500 and 1 in 5,000 people. And it can be scar tissue formation around the heart or in the lungs or in the gut. Again, life-threatening. So what you want to design, if you could design the medicine, is a serotonin activating, a receptor activating drug that includes perhaps blocking the bad receptors while activating the good receptors. And it's not clear where this stands. This also has implications for Parkinson's because some of these drugs overlap with anti-Parkinson's medicines. And the hope is that one of these synthetic serotonin specific medications will be tested, get through phase 1 and move into phase 2.
Wow, that's pretty amazing and so complex as well. If you
I
were
don't-
to, I don't know if you know the answer to this question, but if you were to estimate how many different molecules or potential treatments are studied versus the ones that actually come to market.
Oh boy, it's amazingly high number of potential compounds.
Right.
And what the companies have developed is these are massive computerized systems to work through chemical after chemical after chemical after chemical and see if they can match what is known about receptor or mechanism of action for a particular therapeutic area with a particular chemical. And they test uncounted thousands of potential chemicals before they decide to zero in on one for a little bit closer look.
Right. Interesting. And is AI helping with that process? I would imagine it is tremendously, right?
Yep.
Interesting. So let's back up and look at botulinum toxin A. And a lot of people might be saying, why are you talking about that? Because we've had Botox out for a while, but there are 4 different aspects of this. The first being looking at botulinum toxin A, hopefully I pronounced that right, for episodic migraine, not just chronic, right?
Yes. So that, first of all, just in case you are not aware of this, the type of, there are different kinds of botulinum toxins, and these are all of these can cause botulism, but they are different biological compounds. And the one that is used most frequently is botulinum toxin A. The FDA puts in a little prefix before it, and there are different kinds of botulinum toxin A's that are commercially available for different indications. Onabotulinum toxin A, abobotulinum toxin A, daxibotulinum toxin A, and so on. Onabotulinum toxin A is Botox.
Right.
Botox has a lot of FDA approval for different indications, but currently, from a migraine standpoint, is only approved for chronic migraine. That is, 15 or more headache days per month for at least 3 months.
Right.
Um, the other botulinum toxin A's have not yet been fully studied for migraine prevention,
Okay.
but 3 of them are currently being studied. One of them, and before I leave Botox, botulinum toxin A, Botox, is being studied for episodic migraine prevention, that is less than 15 headache days per month. The study is done, we just don't know the results yet.
Okay.
And we would assume that the results on that study would be made public sometime in the next year, next 6 to 12 months. It was a very large study. They're going to need to really work on the data. The second botulinum toxin A that is being studied is abobotulinum toxin A, and that is has a brand name of Dysport.
Right.
Dysport is being studied again. One of the studies is for episodic migraine. One of the studies is for prevention of chronic migraine. And the 2 studies are called E-Beyond and C-Beyond for episodic and chronic migraine. And these are, again, big studies for regulatory approval. If they're positive, then there'll be a second botulinum toxin A that would probably get FDA approval for prevention of migraine. Third botulinum toxin A only has a number, ABP 450, and that also had 2 studies, one for episodic and one for chronic migraine, and those studies are being written up for publication. And the full results of those studies have not been fully publicly commented on. And then the last is a small study of daxibotulinum toxin A for migraine prevention. That one is approved. Daxify is approved for cosmetic usage at this point. So we have 4 that are being studied, and we'll see. It'd be great to have some extra botulinum toxins with slightly different formulations and slightly different ways to inject. Some of the injection paradigms for these studies are a lot simpler than for Botox. We'll see. There is also a botulinum toxin B that's available. That one is not currently being studied for migraine prevention. But there's a lot of action on the botulinum toxin side, and we should have a lot more information by a year and a half from now, sometime in the next year to year and a half.
Wow, that's great to know. So there's just more options coming up. And then take it a slightly different angle. I think one of the greatest frustrations for parents who have children with migraine is that so many of the options are not have not been tested on children, and so trying to find appropriate treatments for people under 18 has been tough. But there have been some studies on the GPANs and the MABs, the CGRP inhibitors, correct?
That's correct. And we hope, again, to have answers over the next year to year and a half. And the hope is that these will work nicely in younger age groups because of the low side effects and the high effectiveness. It's been one of the discouraging aspects for kids that the really big study that the NIH sponsored, called the CHAMP study, which evaluated the usual kinds of medicines that are prescribed for kids. I can't remember all of them, but amitriptyline and propranolol and topiramate. In this very large study that was done over multiple centers, those drugs for kids didn't work any better than placebo. So that's the biggest study for pediatric prevention that's been done. And my assumption is it's because those older drugs are not very good. We all know that. Most people hate them. And the American Headache Society position statement that was published in April is that for adults, when it's appropriate, they shouldn't even be made to take those older drugs. They should move right to the migraine specific anti-CGRP prevention. And my hope is that the increased effectiveness and decreased side effects of these medicines will prove effective in kids, and it'll open a new era for the treatment of pediatric migraine. That's my hope.
Yeah, my hope definitely too. All my children are now in their 20s, but they will be having children. And so it's really heartbreaking as a parent to see your child suffer and not know what is safe to give them to increase their quality of life. What about glutamate? So I have this on my list. Is that a preclinical or phase 1 study?
Well, glutamate has been a target for a long time. Glutamate is a bad actor. And the glutamate is a little bit like a foot. It can go to an accelerator and a brake and a clutch with respect to your foot with a car. And glutamate has different receptors that it activates. But almost all of them, when glutamate binds to these receptors, bad things happen. And glutamate activation of some receptors is associated with bad outcomes in stroke, for example. Glutamate activation is associated with PTSD, with bad pain conditions. And there have been over the years many antagonists to the glutamate receptors that have been tested, and some of them have showed modest benefit in migraine, but the side effects of targeting glutamate and of having anti-glutamate effects, such as hallucinations, have turned into a big problem in developing anti-glutamate medicines. So right now, I think that one probably is not likely to see the light of day for us. We do use some of the anti-glutamate medicines off-label when simpler measures have failed in some patients.
Right. Interesting. Yeah, very interesting that. Just to remind people, we have about 15 minutes at most left. If you have any questions that are new, then please put them in the comments now so we can get to them. We still have some more things to go over here. And I know that we're covering a lot of ground very quickly. So let's look at some of the medical devices that are in various stages of clinical trials. You know, everybody who knows me as a migraine advocate knows that I'm passionate about medical devices and believe that we should all have at least one of these in our toolboxes. But now we have some new options that are coming through. So why don't we start with Nocera?
Nocera is a device that sits over the ears like earmuffs, and what it does is it slowly, through puffs of air, puts pressure on the eardrum and then releases those pressure on the eardrum. And the question is whether, because the pathway from the ear into the brain is very close to the pathway for pain into the brain, because the eighth nerve, which is the ear nerve, is close to the fifth nerve, or the trigeminal nerve, which is the pain nerve for the front of the head. The question is whether there's crosstalk within the brain that can help with prevention of migraine with this device. And a number of studies that have not been fully published but have been presented at meetings show some hope with this device. Of course, the idea would be that this would be another of the non-significant risk devices, of which currently there are 8 non-invasive neuromodulation devices FDA cleared, and 6 out of 8 are designated as non-significant risk devices. I too try to integrate non-invasive neuromodulation in my practice every day, and the biggest problem, of course, is payers.
Right, absolutely. Huge
Yep.
issue and so frustrating, for patients as well as clinicians, obviously, especially if you just look at it from a cost factor. If this works, why would you not cover, a medical device and you choose a medicine?
So upsetting.
Yeah, it really, really is. So let's talk about SheraTronics. So they have, I'm not sure if it's a device or the trial name, Relieve CM. I know they have finished their first trial in Australia and are looking at starting one here, or have already started, but it is an invasive medical device, not a non-invasive one.
So this is a device that will be implanted and put under the skin all the way across the forehead, over the supraorbital and supratrochlear nerves, and then the battery for the device sits over the ears, and then every night person has to put on a little sort of like headphones, but it sits above the ear to recharge the battery, and the device stays on for the prevention of chronic migraine. And a large pivotal trial is underway in the US for this device. that's where things stand. The idea would be that it would send a negative signal, an inhibitory signal through those nerves over the eyebrows and around the eyes. And those are the same nerves that are targeted by the currently available non-invasive neuromodulation devices, Cephally, Hedaterm, and Relivion
Right.
in the front. So this would be continuously stimulating the same area that we have patients do for, say, 20 minutes nightly with the non-invasive devices.
Wow, that's interesting. I mean, we've been so interested in the non-invasive ones. It's easy to kind of not even consider something like that, but there are so many people who are desperate, right? That this just may be a wonderful, amazing option for it. How long does a clinical trial for something that is a medical device, but that is implanted like this? How long are those trials likely to last, or is that just open-ended?
Well, I'm trying to remember whether in the public domain it said whether it's a 3 month or a 6 month preventive trial. Once the thing has been implanted and heals, and then it's got to be a big pivotal trial, and some of the patients are not going to have the active stimulation. They're going to have a sham stimulation, and then there's going to be a safety extension trial. So I
Right,
would think, again, minimum of a year and a half to 3 years for this
right.
trial.
Right. And again, migraine heroes, they're going in and having a clinical trial and risking having a placebo implanted.
Right. But
It's
I bet they
amazing.
have I don't know for sure, but I think they have an open label. So
Right.
if the people get placebo for whatever the initial period is, they'll turn it on
I get
late.
that afterwards.
Yeah. But
Yeah.
still, it's a surgical procedure. So with all of that entails.
Yeah, absolutely. No, definitely. Before we talk about Nerivio for the younger ages, we'll do in just a moment. I see there's another device on our list called the Pulsante or the Pulsante. Not sure how you pronounce that one.
Yeah, this is kind of old news, but there's a little bit of new news on it. This was a device that was implanted through the mouth, again, requiring surgery, and then the device is screwed into the skull above the teeth and sits in a little area outside the brain called the sphenopalatine or the pterygopalatine fossa. And the device sits over the sphenopalatine ganglion, the
Right,
SPG ganglion.
right,
And the great thing about this device is it doesn't have any batteries, it doesn't have any wires. Everything in this device was in a remote controller that is both programmable and rechargeable. So person would put it on the cheek and turn it on for whatever period of time for whatever use. And this device was studied for cluster headache,
right.
and it was effective in both terminating cluster and in preventing cluster. And it was approved in the EU, and it was actually reimbursed in Denmark and Germany for cluster patients who are desperate, and it worked
Wow.
very well for them. And then the company was mismanaged and went bankrupt. And were not able to renew the license in Europe. The American study was completed and published and was positive. And another company has bought the intellectual property and the devices for, I don't know that they'll call it Pulsante anymore,
Right.
of this SPG stimulator. And I think they're going to try to resurrect it, but it's been years since the company went bankrupt. The other company went bankrupt. So we're hoping for our cluster patients that it is given a new life because we know it works. It already got approved in Europe.
Right.
It would really be great if we could get it for our cluster patients. And it probably needs to be tested in migraine as well.
Right. That was going to be my next question. Is it going to be? I remember reading about it a while ago for in Europe and just hadn't known what became of it. So very sad that the company went bankrupt. Let's talk about Nerivio. So Nerivio currently is approved for adults and also approved for adolescents, I think 12 plus. But ideally, it would be great for younger ages. So is that in clinical trials for younger than 12?
Better than that, my understanding is, first of all, there was a case series of its use in younger kids below the age of 12, and it seemed to work. And my understanding is that the company is in discussions with the FDA. We hope that very quickly the FDA is likely to clear it for younger kids. And I've already started using it in younger kids off label. and for adolescents. And it's such a lovely device for kids because it really doesn't have side effects. They can put it on the arm underneath their clothes. They can turn it on, use it every other day for 45 minutes to prevent migraine, use it as needed. It's a non-significant risk device. So fingers crossed, we hope that by the end of the year it'll be cleared for the younger kids too. And it's important to remember that a few of these devices are the only therapies that are FDA cleared for prevention of migraine in kids.
Right.
And they include the non-invasive vagal nerve stimulator, gamma core, and I think the single pulse transcranial magnetic
Right.
stimulator, I
Savvy
believe,
dual. Yeah,
and
savvy dual.
Nerivio. So all of those are really, they do work in kids and in adolescents. They're
Right.
cleared in adolescents, but we don't have anything for younger than
Right.
12 years old. So the big hope is that Nerivio gets cleared for the younger ages by the end of the year, sooner
Right.
rather than later. And it's very exciting. And I can say that when I take care of teenagers, which I'm doing more and more, they're not really that enthusiastic about going on medicines.
Right.
And we don't have approval for the anti-CGRP therapies for them. And the older medicines failed in that big federal study. So I'd say to an adolescent sitting in front of me, you don't really want to take pills, do you? And he'll say, no, I don't want to take that. What about a device that can go on your arm that you turn on when you need it, or you do it every other day? Oh, yeah, I would do that. So I think the kids are more amenable and more receptive to non-invasive neuromodulation. The parents are relieved that we
Right.
have something that's FDA cleared and is non-significant risk, not a drug.
Yeah, absolutely. It's very interesting. I know that my organization is finished doing a young adult with migraine study. We're actually doing posts all this week. So for those who are listening, check out our social media channels, and we have a summary report we're going to put on our website. But we did a very small qualitative study on adults aged 18 to 25. And, I have two children who are in that age range. Obviously, they're not children anymore, and I learned so much that I never knew, from my own children, but sitting in this study and listening to them talk. And one of the things was they don't want to take pills either. They just really don't. They're just adamant about it. So it's very interesting. I love seeing these devices being tested on younger children. I wish they were around when I was young. I wish around when my children were really young. But hopefully this will be approved soon for younger children as well. And so that's great news. I think we've actually got through our list and we're almost at time. So have I forgotten anything, Dr. Tepper? Is there anything we haven't covered that you think we should cover today?
No, I think, I mean, there are always a few extra things that are going to be developed that I won't have covered, but I just wanted to give a message of hope that there really are quite a lot of new nooks and crannies and therapeutic targets and formulations, all of which might be helpful to people. And I've been doing this a long time, and this is by far the most exciting time for people with migraine because we have so much to offer, and the opportunities for treatment are vast. The new classes that are being studied are intriguing, and I'm quite excited about them. So I want to leave you with that message of hope. This is really an exciting time, and we hope that we can help every person who comes through the door with migraine.
Right, absolutely. I totally agree with you. I mean, if we're thinking that, the first acute medications were, decades ago, and then we had this big space before the first migraine
Very
specific prevention, but now we have all of these different options in the pipeline. That's exciting. So, if you're out there and you're losing hope, please don't. There is hope out there. As many of you know, I'm one of those people desperate to find something that works better. And that's why I'm so passionate about what I do here. And I love talking with Dr. Tepper about this because he's so knowledgeable. So thank you everybody for being with us today, and for those who watch the video afterwards. I hope that you found this helpful. This is being recorded. It'll be up on our YouTube channel, and there will also be a summary of each of these different options on our website. There's some of it up there already, but you'll be able to look for more in the next couple of days. If you have comments or questions that have not been answered, please let us know, and we will do everything we can to get those answered. We know that migraine is such a challenging disease to live with, and we encourage you to educate yourself about both the current options available and those that are in this amazing clinical pipeline, and then to proactively partner with your doctor to help manage migraine in your life. Thank you, everybody, for being with us today. Thank you, Dr. Tepper, so much for joining us. We really appreciate it.